I want you to cast your mind back for a moment. Just try to imagine you're a healthcare worker standing in a hospital ward at the very start of the 2020 pandemic.
Oh, man. Yeah, a pretty heavy place to start.
Right. I mean, the hospitals are overflowing. There is this invisible, rapidly spreading virus, and it is just causing absolute chaos.
Complete chaos, yeah.
But imagine you have access to some of the most cutting-edge medical software in the world.
Okay.
But there's a catch. All of that software, all of that incredible processing power, it's entirely focused on detecting the virus in patients who are, already sick.
Oh, right. Like reading lung CT scans for congestion patterns.
Exactly. Or analyzing blood work after a patient is already admitted. It's incredibly advanced, but it is ultimately reactive. It's only telling you what has already happened.
Right, the damage is done.
Yeah. But what if software could tell you who was going to get sick before it even happened?
I mean, that is the ultimate holy grail of epidemiology. Moving from detection to prediction. Because if you can accurately predict who is most vulnerable before they ever even encounter a pathogen.
You can actually do something about it.
Exactly. You can allocate resources more effectively. You can warn specific populations. You basically get ahead of the invisible spread instead of just constantly chasing it.
And that transition, going from reacting to predicting, that is our central mission in today's deep dive. Welcome, everyone.
Glad to be here for this one. It's a fascinating topic.
It really is. Our goal today is to explore this fascinating research chapter by Kenneth David Strang. It's titled, How Could Machine Learning Help Healthcare Informatics Predict Coronavirus?
Such an interesting paper.
We're basically trying to discover how analyzing retrospective hospital records using artificial intelligence might just act as a kind of crystal ball for future pandemics.
It represents a complete paradigm shift, honestly.
Yeah.
We're talking about utilizing these massive troves of past data, things that seem entirely unrelated to a new virus, to map out hidden vulnerabilities.
It really changes how we look at, every single data point a patient generates over their lifetime.
It does.
Okay, let's unpack this. Because to understand how we can actually predict the future, we first have to look at a massive and honestly quite famous predictive failure from the past.
Yes.
Because using data to track viruses, that isn't exactly a brand new concept, is it? People have tried this before.
They definitely have. And the history is highly flawed, which, perfectly sets up why Strang's research here is so revolutionary.
Right.
If we look back to the years 2009 to 2011, there was this highly publicized project called Google Flu Trends.
Oh, I remember hearing about that.
Yeah, the concept was actually elegant in its simplicity. Google basically used their AI to track what people were searching for in their browsers.
So just mining search data.
Exactly. They monitored millions of queries for keywords related to flu symptoms, flu remedies, thermometers, that sort of thing.
Mm-hmm.
And for a brief window, it worked brilliantly.
Wait, really? It actually worked at first?
It did. They provided estimates of flu activity across the United States and actually 24 other countries that were faster and more accurate than the CDC's own clinical predictions.
Wow. I mean, the underlying logic does make sense on the surface. Like, if someone in my house is running a temperature, I'm probably going to search for, I don't know, how to reduce a fever.
Right, exactly.
So the search volume correlates to illness volume.
That was the idea.
But that success obviously didn't last. The wheels completely fell off the wagon just a couple of years later, right?
Spectacularly so. During the 2012 to 2013 flu season, the AI completely failed.
Oh,
I
wow.
mean, it overestimated the number of flu cases by more than double.
More than double. Yikes.
Yeah. The CDC's traditional, slower predictions ended up being accurate, but the AI was wildly off base. And what's fascinating here is why it failed.
Okay, why? What went wrong?
The fundamental flaw was that self-perceived symptoms, literally what people type into a search bar, became a proxy for actual clinical medical diagnoses.
And human behavior is incredibly messy.
Very messy.
The research actually points out that user paranoia and herd behavior completely hijacked the data.
That is the core mechanism of the failure right there. Just think about how news cycles work.
Oh, yeah. Pure panic.
Right. If there's mild hysteria in the media about a so-called super flu season, people panic. They feel a slight tickle in their throat, and because they're anxious, they don't just search once.
They search 5 times.
Yes. And they text their friends, who then also start searching.
Right.
So the algorithm couldn't distinguish between a legitimate medical symptom and socially induced anxiety.
Mm-hmm.
It just fed on the panic, creating this massive feedback loop of highly inflated data.
Which is a huge problem.
And that data failure has real-world consequences.
Yeah.
It led to massive over-preparation, which cost health providers valuable time, money, and resources, basically chasing a ghost.
That's like trying to judge the actual temperature outside strictly by counting how many people are buying sweaters online.
Yeah.
Measures panic, not weather.
That is a perfect way to visualize it. You are measuring the human reaction to the environment, not the environment itself.
Right.
Because search engine data is so incredibly noisy and prone to this kind of psychological manipulation, healthcare professionals realized a hard truth.
Which is?
If you want to predict medical outcomes, you cannot rely on proxy internet searches. You need verifiable, clinical medical data.
Which brings us to the promise and honestly the absolute peril of healthcare big data.
Oh yes, the peril is real.
Because the moment you say, hey, let's just gather actual medical data, you introduce a technological nightmare of just unprecedented scale.
You really do. When data scientists talk about big data, especially in healthcare, they refer to the 5 Vs.
The 5 Vs, okay.
Volume, variety, velocity, value, and veracity.
Yeah.
We aren't just looking at a flat spreadsheet of patient names and blood pressures anymore.
I really want to break those down because the examples in the source text completely blew my mind.
They're pretty wild.
Let's start with variety and velocity. We aren't just talking about a doctor typing notes into a file. The text mentions GPS-enabled asthma inhalers broadcasting real-time usage across a city using radio frequencies.
Incredible. Right.
It also mentions microtechnology implants inside a patient's body, transmitting continuous sensor readings.
And that ties directly into the volume aspect. The sheer amount of data being generated is almost incomprehensible. This isn't data entered once a year at an annual checkup.
Right, it's fire hose.
Exactly. This data is broadcasting constantly, 24 hours a day. Then you have variety, which means the data comes in wildly different formats.
Like what?
Text notes, high-resolution MRI images, continuous numerical streams from a heart monitor. Mixing all of those formats together into one coherent analysis is just incredibly difficult.
Let's do the math on the volume aspect, actually, because there is this staggering reality check in the text that really grounded this for me.
Let's hear it.
Okay, let's say you have a single, relatively simple medical device attached to a patient. It transmits just 4 tiny pieces of information: a patient number, the time, their location, and their body temperature.
Simple enough.
And it pings that data every single second. That generates over 31 million records a year, just for one patient.
It adds up so fast.
It does. So if a researcher wants to track a simple cause and effect relationship, say, how a specific drug affects the temperature of just 100 patients over a year, that generates 6.4 billion individual records.
And keep in mind, that is a laughably simple query for modern medicine.
Right.
Now imagine adding heart rate, oxygen saturation, sleep cycles, genetic markers, past infections, and doing it for millions of patients simultaneously.
That creates a massive bottleneck.
Yes.
The standard software that scholars and researchers have relied on for decades literally breaks under this weight.
Just can't handle it.
Like the desktop version of STSS, which is essentially the gold standard for statistical analysis and research, it has a hard mathematical ceiling. It maxes out at exactly 2,147,493,647 cases. It simply cannot hold the 6.4 billion records you'd need for that basic 100-patient drug study.
It's a hard structural limitation,
Yeah.
but, the physical size of the data isn't even the most dangerous peril here.
Yeah.
No, there's also veracity in the truthfulness of the data. And more specifically, the danger of the data basically lying to you through sheer mathematical coincidence.
Oh, this is fascinating.
There was a study by Fan, Han, and Liu in 2014, and it highlighted a phenomenon called spurious correlation.
Spurious correlation.
Right. They proved that if you have a data set with just 800 independent features, which, by the way, is tiny in the realm of big data,
Yeah, almost nothing.
there's a 50% chance that traditional statistical tools will find a statistically significant correlation purely by random chance.
Meaning, if you throw enough random numbers into a traditional stats program, it will confidently tell you that eating bananas on a Tuesday prevents broken legs, just because the math accidentally aligned in the noise.
Precisely. The uninformative features eventually overwhelm the actual informative signals. The noise drowns out the music.
Wow.
And we really can't ignore the darker side of veracity, which involves security and privacy. The text cites chilling cases where the data streams from medical devices like insulin pumps and pacemakers were electronically hijacked.
That is terrifying.
It is. The very signals designed to keep patients alive, the same signals generating this predictive data, can be intercepted or manipulated.
Jeez.
This raises an important question. How do researchers safely and accurately analyze a database that is literally too massive for traditional computers to hold without being fooled by false patterns and while maintaining patient privacy?
Well, that is exactly where traditional statistics have to step aside, and artificial intelligence takes the wheel.
Exactly.
Because those older tools break under the weight of billions of records, the researchers in Strang's study had to embrace a totally pragmatic, mixed methods approach utilizing machine learning.
Let's examine their starting point because it's pretty impressive. They were given access to a massive, HIPAA-compliant, completely anonymized database of patient vitals,
Right, completely private.
spanning an entire decade, from 2010 to 2020.
We are talking about 4,192,000 patient records. And each of those individual records could have up to 2,400 distinct medical fields.
Furthermore, it wasn't perfectly clean laboratory-grade data. It was real-world clinical data.
Messy data.
Very. That means it was full of missing entries where, say, a nurse forgot to log a chart, or corrupted fields, partial histories. To make this computational nightmare manageable, they used a technique called systematic random interval sampling.
Okay, let's demystify that term for a second. What does systematic random interval sampling actually mean in practice?
Well, instead of trying to process all 4 million records, which would crash the system, you decide you only need a representative slice.
A sample.
Right, but you can't just pick the first 1,000 files, because they might all be from the same hospital on the same day.
Oh, sure, that skew everything.
So you pick a random starting point, and then you select, say, every 100th record. It ensures you get a deeply randomized, unbiased cross-section of the entire decade of data.
That makes sense.
Using this, they distilled those millions of files down to a highly robust, computationally valid sample of 1,147 records.
Okay, but even with that smaller sample, you still have thousands of variables per patient. If they used standard regression analysis, it would just spit out those false, spurious correlations we talked about, the banana and broken leg problem.
Exactly.
So they utilize a specific AI tool called random forest classification. How does random forest handle this kind of chaos without falling into the trap of false patterns?
What makes random forest so powerful here is its fundamental approach to problem solving. Traditional statistics usually demand that you ask a specific targeted question up front, like, does high blood pressure cause this disease? Random forest goes in completely blind. It doesn't need a target variable at the beginning. It looks at the massive cloud of data and uses mathematical concepts like entropy and Euclidean distances to find its own structure.
Okay, those are heavy data science terms. Let's break them down. If I'm visualizing Euclidean distance, am I just picturing the AI plotting every patient on a giant multidimensional graph and literally using a digital ruler to measure the physical space between their data points?
That is an excellent visualization, actually. It maps out all 2,400 variables for every patient in virtual space. If your dot is very close to my dot on this massive graph, it means our medical histories are mathematically similar.
Okay, I follow.
The algorithm uses that distance to start grouping similar patients together, and it uses entropy, which is essentially a measurement of chaos or disorder, to figure out the best way to split the patients up.
So it's trying to clean things up.
Exactly, it wants to reduce the chaos.
Mm-hmm.
It looks for the specific variables that most cleanly separate the patients into distinct, highly organized groups, which it calls trees.
And a bunch of trees makes a forest.
You got it.
So it's kind of like, think of random forest as a massive mathematical sorting hat.
Oh, I love that. A mathematical sorting hat.
Yeah, but it doesn't look at a patient and say, you belong in this group because a doctor told me to put you here. It looks at thousands of tiny, seemingly unrelated traits, measures how close those traits are to other patients, and groups you with people who have the exact same underlying biological patterns.
Even if those patterns are entirely invisible to the naked eye.
Right?
I love that analogy because it highlights the lack of human bias. It finds the hidden architecture within the data on its own. And importantly, it handles all those missing, messy, real-world data points beautifully.
How so?
Because a random forest is made up of hundreds of individual decision trees, they essentially vote on the outcome. If a few trees get confused by a missing data point or some random statistical noise, the vast majority of the other trees will overrule them.
The noise is naturally averaged out. So, once the random forest algorithm finished organizing this chaotic sample into three distinct mathematically pure clusters, it did something crucial.
It really did.
It ranked all of those thousands of medical fields by their predictive importance. It essentially handed the researchers a list and said, these are the specific data points that most strongly define the differences between these patient clusters.
And the result it produced completely defied conventional medical wisdom at the time. Remember, the ultimate goal here is trying to figure out vulnerabilities to coronavirus.
Right, and I want to pause and ground this in what we all actually lived through.
Yeah.
Think back to the early days of the pandemic. The universal narrative, the driving force behind every public health decision was age.
Age, absolutely.
Lockdowns, hospital triage protocols, the entire phased rollout of the vaccines, it was all strictly tiered by age. Age was the undisputed king of risk factors.
Age was considered the absolute prime variable by human clinical standards. But the machine learning model, looking purely at the math without any media narratives or human assumptions, saw it very differently.
It really did. Out of thousands and thousands of variables, age was only ranked as the 10th most important factor by the AI.
10th.
That is a staggering disconnect from what we thought we knew. So what were the top predictors then?
The top three most important fields, the strongest predictors identified by the AI sorting process, were all related to something called AHI, specifically Ahinoram, Ahiram, and total AHI.
What exactly is AHI and why would the AI care about it so much?
So AHI stands for the apnea-hypopnea index.
Okay.
It is a very specific metric used in sleep studies to measure the severity of sleep apnea. It records events that disrupt normal sleep where a patient's airways partially or completely collapse.
Oh, wow.
When this happens, their breathing either stops entirely or lowers significantly for at least 10 seconds. And this causes the oxygen levels in their blood to plummet to dangerously low levels, sometimes dropping to just 10% to 30% of their normal baseline.
So the AI sifted through an entire decade of data, looked at thousands of variables, and decided that how a patient breathes while they are unconscious, the specific severity of their sleep apnea, was the single most mathematically defining feature of their medical history when grouping these patients for viral vulnerability.
Yes, it's wild. But as we discussed earlier with spurious correlations, mathematical grouping means absolutely nothing if it doesn't hold up in reality.
True.
To see if this AI-generated cluster actually meant anything regarding the pandemic, the researchers ran a real-world simulation.
Right, because up to this point, it has just been a highly advanced sorting exercise. To actually test it, they followed up on those sample patients a full year later to see who had actually caught COVID-19.
The moment of truth.
They took the AI's top predictor, the AHI sleep data, and ran it through a statistical test called logistic regression against the actual documented infection outcomes.
And the results of that simulation were highly compelling. The model proved to be remarkably accurate at predicting who got sick. It achieved a 70.4% overall accuracy and a 90.1% specificity rate.
Let's translate that specificity rate for a second because that's a crucial term.
It is.
Specificity measures a test's ability to correctly identify people who don't have the condition. So a 90.1% specificity means that if the AI model looked at your records and said you weren't highly vulnerable, it was right 9 times out of 10.
Which is fantastic.
It was incredibly good at not causing false alarms, which is exactly what Google Flu Trends failed at.
That is a vital distinction. It didn't overpredict. Furthermore, the researchers calculated an odds ratio of 1.296.
Which, in plain English, means what?
It means that, based on this simulation, patients with these specific sleep-breathing disorders had roughly a 30% higher chance of contracting the coronavirus compared to the rest of the sample. The AI successfully found a true predictive signal hidden deep within the noise of thousands of other routine medical records.
Okay, here's where it gets really interesting.
Yeah.
I need to push back hard on this for a second.
Sure.
Are we saying, is this published study actually claiming that sleep apnea causes COVID-19? Because that sounds like a massive, deeply irresponsible leap.
If we connect this to the bigger picture, it is absolutely vital to clarify that no, this is not a medical breakthrough declaring a new causal mechanism for the virus.
Okay, yeah.
This is not a clinical study proving that sleep apnea actively invades the COVID pathogen into your body.
So if it's not clinical proof of a cause and effect relationship, what is the actual tangible value of this finding? Like, why does this matter?
The immense value here is in the methodology itself. It is a proof of concept simulation. The researchers weren't setting out to cure COVID-19. They were setting out to prove that artificial intelligence, specifically machine learning models like random forest, can successfully navigate the impossible volume and variety of healthcare big data. The breakthrough is proving that an algorithm can sift through the messy, noisy, seemingly completely unrelated medical history of a patient, like a routine sleep study done 5 years ago, and use it to accurately predict their vulnerability to a viral pandemic that didn't even exist when the data was originally recorded.
That is just wow. It's the ultimate proof that the data holds the answers if we just have the right computational tools to read it without human bias getting in the way.
Exactly.
Which brings us back to you listening to this deep dive right now. Whether you are a healthcare professional strategizing for the next wave, an informatics specialist dealing with server loads, or just someone trying to understand where the future of medicine is heading, this research shows us something profound.
It really does.
The era of merely reacting to diseases, of waiting for the x-ray to show the lung damage or the blood test to confirm the infection, it's ending. We are standing at the threshold of truly predictive healthcare.
We are moving from a defensive, reactive posture to a proactive one. And that transition relies entirely on the massive streams of data we are generating every single day.
We are entering an era where your smartwatch heart rate logs, your historical pharmacy records, your seemingly random past vitals, they could be the exact data points a hospital's AI needs to prepare for a novel pandemic before it even strikes your city.
It is the science of turning hindsight into foresight,
It is.
which leaves us with a fascinating and perhaps slightly unsettling thought to consider.
Okay, leave us with it.
If a machine learning algorithm can look at how you breathe in your sleep today to accurately predict your vulnerability to a completely novel virus tomorrow, what other invisible risks and hidden strengths are sitting undiscovered in your digital health footprint right now?
Oh man, that is a brilliant question to leave off on. Thank you so much for joining us on this deep dive. Keep questioning the data around you, and we will catch you next time.